And if you want to get my attention this morning, just go ahead. You can wave at me. If I have the PowerPoint up, I necessarily won't see you because I can only see the PowerPoint, but I have the chat so I can see your comments. So go ahead and pop them in there if you need to get my attention. So what we're going to do is go ahead and put the PowerPoint up, Carla, for me. And what we're going to do then is go ahead and kind of run through some housekeeping really quick. So here we are for the PowerPoint. And we'll go ahead and go to the next slide. So data usage, you guys, this is the echo movement. So we're going to record who's with us. And we've got the information from the didactic and the case presentation. So just to kind of let you know, this is for quality assurance activities and decision-making related to new initiatives coming in the future for ECHO. So, okay, so joining by video, mute yourself. If you can keep yourself muted unless you're going to talk, that's helpful because otherwise we can hear every rustle of paper, etc. We ask you to avoid multitasking and stay with us. And when talking, look into the camera, which is really hard for me because I want to look at the screen above it. So I'm sorry, I'm going to try and make eye contact with you, but I know I get off on that one. So the next slide, please. Okay, so initially, this is when I told you about that feedback that we got. You can be in with the computer or the phone, but not both. If you're having trouble hearing us, this is where you can set up your system so to make sure that you can hear us once you're logged in. So just go ahead and take a look at those directions. And then also I put up here a little picture of where's the chat. It's down on the bottom, kind of toward the middle to the right. And then if you want to unmute yourself in the video, it's on the left. Okay? So, and this is what the chat looks like. A word of caution, when it says to everyone, whatever you type in there, everyone will see. You can change that setting if you want to just send it to me. You'll have to get that little arrow and then it'll pull down and you can pick who you want to talk to, just a FYI. Okay. So today, who are our participants? So you can see our hub subject matter experts are Alina Health, Children's Minnesota, Hennepin Healthcare, M Health Fairview, North Memorial, and Sanford Health. And then our spoker learning organizations are the Community Health Services, Inc. And our Entira Family Clinics, Fairview Mesabi Clinic Hibbing, Lake Superior Community Health Services, Open Door Health Center, and Ortonville Area Health Services. So these are our folks that will be joining our call. And our next slide is. So today, remember now, folks, go ahead and put yourself on mute because I can hear some feedback. Today, what I wanted to do is we're going to introduce the team from Sanford. I'll let you guys introduce yourselves. They are going to do optimized team collaboration in integrated primary care settings. So Jeff, do you want to go ahead and do the introductions and go ahead and get started with our didactic today? The other thing is I just wanted to remind you guys that we are recording this so that we have this for the future folks to go ahead and see. And those that have joined us a little bit late, go ahead and put your name, email, and organization in the chat so that we can give you attendance and let know who's been here. So Jeff, go ahead and make your introductions and get started. Thank you.
Thank you, Jeyn, and good morning, everybody. My name is Jeff Leichter. I'm a psychologist with Sanford Health, and I have two of my good friends and colleagues with me, John Alagata, who's a psychologist in Detroit Lakes, and Megan Hansen, who is a clinical social worker in Bemidji. Jeyn has asked me to give just a 10-second overview of Sanford Health. We are a not-for-profit rural health system that is located primarily in North, South Dakota, Minnesota, Iowa, and Montana, although we also have extended care facilities around the United States due to a recent merger with the Good Samaritan Society. But our main medical care facilities are in those 5 states. Sanford has about 50,000 employees and close to 500 clinics of which about 50 or so are currently practicing full-time integrated behavioral health. So we are delighted to provide the didactic this morning. I told Jeyn that we're going to try to keep it tight because we've got a lot of information to present in 10 minutes. So if you want to advance the slide, Jeyn, that'd be great. We're pretty boring at Sanford. We don't have any conflicts of interest. Next slide. And based on the cross-model framework that we're all familiar with, we'll be focusing mostly today on what you see highlighted there in yellow around optimizing team-based care, communication, and trust. And these are things that we do try to actually practice at Sanford, not just pay lip service to. If you want to give the next slide. Here's our learning objectives, pretty simple given that we only have 10 minutes. We want to just present some very brief research to you all related to optimizing team-based care with regard to both individual factors and cultural factors, and then hopefully help you to apply any insights that you develop to improving the interprofessional collaboration in your setting. Next slide. So what I'll be presenting briefly is just some information from the Interprofessional Education Collaborative. For those who may not be familiar with IPEC, that is an organization that started in 2009 and is now comprised of 21 health profession guilds that cross over a number of different health professions, and their mission is to promote interprofessional collaborative practice. And these are what they have published as 5 important values for optimizing integrated care. And I'm just going to talk very briefly about each one of these. So the first one is honesty. And this really refers to a culture of openness and vulnerability and non-defensiveness about both the highs and lows of things that the interprofessional team accomplishes, and basically to take good stock of what we do well and where we can do better. The second value is discipline. And for us, we interpret this as a commitment to excellence in carrying out each individual's role on the integrated behavioral health team, especially when it's inconvenient, especially when it may not be easy. The third value is creativity, and the way that we interpret that is to try to foster a sense of excitement about integrated behavioral health, to court new ideas, and to see errors as opportunities for growth, not something that we hang our head about, but really just a bump in the road that we try to use to increase and improve our impact. Next slide. And the fourth value from IPEC that we try to incorporate is humility. This is a value that personally I hold very dear. And this is really a shared belief that all team member contributions are equally valuable, and each member represents a needed presence on the team. And then lastly is curiosity, which I think of as being an intellectual hunger. And this is our shared value of continued interest in improving our own work and the work of the team as a whole. I know that's a lot of information to digest, but given the time, I'm going to hand it over now to my friend Megan Hansen, who will tell you a little bit more.
Next slide, please. Can you hear me?
Yes, Megan, we can hear you.
Okay, perfect. There we go. So I'm going to talk about 5 essential principles of integrated care. And our list here has a culmination of information from SAMHSA and also the Institute of Medicine. So the first one we want to highlight is strong leadership. What we've found within our organization is that having local leadership within the clinics that fully grasp integrated care, along with having what we call enterprise leader, which is Jeff here, who's on the call, that has really been key for kind of looking at how are the different regions practicing integrated care and how can we learn from one another. One thing that we've recently put together within the enterprise was a PowerPoint educational tool specific to clinic directors who are often, as we know, not in the behavioral health field themselves. And so what that has done is really created a nice framework for clinic directors to better understand what does the integrated health work look like, and how can we strengthen that position going forward. Secondly, clear roles is important. So when we think about clear roles, you know, that means kind of a good understanding from our medical teams, the primary care teams that we interact with daily, nursing staff, patient access or reception staff, being able to describe to patients what does it mean if you're meeting with an integrated health therapist, because that title in and of itself isn't always well understood, especially from, you know, providers who maybe haven't worked with an integrated health team member previous. You know, there is that distinction between integrated care and traditional behavioral health. So I think that laying out the clear expectation to the patient is helpful for when they come into the first visit, they know what to expect. They're not meeting with a psychiatrist to get medications or even establish long-term therapy necessarily. So we've really worked at getting more clarity within the whole system of what does our role mean. Thirdly, effective communication, thinking about both written and verbal communication as key to making integrated care successful. We also are in frequent communication with our primary care team providers and team members. You know, that could be through staff messaging, phone calls, in person, you know, just kind of figuring out what works best for that team and how can we make sure that we're communicating on behalf of the patient to provide that quality care. Next slide, please. Fourthly, mutual trust we've found is very important, and the research also indicates this. You know, we need an environment where our providers can come to the integrated health therapist and discuss a patient openly and you know, gain feedback both ways. And I think without that trust, it really creates a barrier, mostly for the patient. So really building trust, having good follow through. Those are some of the things we've used in our clinics. So also this kind of goes back to the third one with the communication. So in my experience, the communication ties directly to the level of trust between the various team members. And fifthly, continual nurturing. So we know that our environments are ever changing, staff are changing, program expectations as a clinic or as a larger system are changing. And so just being cognizant of that and reassessing periodically to make sure that we don't have any things that need to be worked out, or when we do notice that, kind of figuring out what's our next step to keep us moving forward. Because if there isn't that reassessment, I think it's more likely that the integrative care approach could, you know, maybe go in a direction that we don't exactly want it to. So those are some of the pieces related to, you know, the essential principles of integrated care that we've found. And I do have the 2 website links there listed if you'd like to read more from those sources. Thank you. And I'll hand it over to John.
All right, thanks a lot. Yeah, so the topic that I'll talk about briefly is psychological safety. This is a great resource. I'd really encourage people to track down that New York Times article, but what it really discusses is the importance of safety for good group team dynamics. And so, you know, they define it here as a shared belief held by members of a team that the team is safe for interpersonal risk-taking, and generally that there's a sense that when they contribute, they won't be punished or embarrassed for speaking up. one of the things that the article does a great job of really outlining is some of the group norms that are really necessary to create that sense of psychological safety. And they really highlight two important dynamics. One is that members can speak in equal proportion. And two, that the teams have basically really good EQ, which is that they're really good at intuiting each other's nonverbal cues or emotions, and they're able to sense each other very well. And so one of the things is that they really notice that when these two qualities are there, everybody is really safe in providing their expertise, which is something that I think is echoed in the other slides that Megan and Jeff talked about. And so I think this is just important to maybe think about maybe typical medical settings where, if there's really strong personalities that tend to dominate conversations, or people who are pretty, quiet and don't speak up, that might be a clue that the team isn't as effective as they could be. So all of these, I think, segue into the next slide there, which is that how the team takes care of each other, or the relationships between each other, is equally as important as the quest for optimal health. So, being in each silo is important, but being able to take care of each other as a team is important as well. So just the relationships, the quality of relationships is also a very key indicator of how well the team functions. With that, I'll wrap up our portion. See, we're sliding just a little over time, and open up to any questions.
Awesome. Well, thank you so much for sharing all these key pieces. Questions out there that we might have. You can go ahead and unmute yourself and go ahead and ask your question. I don't see anybody waving at me. It's okay to ask a question. I mean, there's a lot of depth to this information that was shared, and application to your specific setting, and these pieces, they're core principles, of course, but really wrap in with the cross-model framework and all the other core principles that are there, evidence-based practice, the teamwork, etc. Any questions popping up? I see Mike Troy. Mike, go ahead and unmute yourself.
Yeah, thanks very much. It was an especially clear presentation, which I appreciate. And I just wanted to ask, it sounds almost as if you were able to purpose-build the system that you have. And, some of the challenge. So to what extent is that true? And to what extent did you have to, kind of evolve it on top of existing?
And I'm not sure, Jeff or John or Megan.
Oh, I think Mike was still talking, but he might have went to
I accidentally
mute.
muted myself, but I think I said the good stuff already.
Okay.
I don't know, Jeff, if you want to answer that, given you've been there since the inception.
Well, again, Mike, I only heard most of the question because you accidentally muted yourself. So what I heard you say was, how do we actually implement this, or how do we go about creating this on top of the culture that was already there? So, first of all, I want to be very honest that, we don't do everything perfectly. We certainly want to try to do our best. We have our ups and downs. Some clinics are much more proficient at this than others. But I think if I were to sum it up quickly in the interest of time, we really try to spend a lot of time on relationship building within our integrated teams. And one kind of corny but very effective example is that when we come together for meetings, we try to ask questions to begin with that we call the check-in. It's very generic, but it's something that has nothing to do with integrated health. So an example of a check-in might be, what was your high school mascot? What's your favorite song? What is the most underrated thing that you can think of? And these kinds of questions, we try to spend 10 or 15 minutes in an hour meeting which might seem a little silly on the outside, but what's really going on underneath is that we are building connections to each other by learning to relate as people and not saying you're the physician, you're the nurse, you're the IHT, but we really value the collaboration of individuals and what they bring as people. And I know that may sound aspirational, but this check-in question, and usually whoever's leading the group will come in with the check-in question, is amazingly effective in really minimizing kind of that territoriality, if you will, between disciplines, because everybody can relate to, what's the silliest thing you did in high school? That might be a check-in question for our team. And once we get around the group, everybody's really pretty loose and feeling pretty connected. So I don't know if that answers your question,
Yeah,
but that's one
helpful.
example.
Thank you.
Awesome. Thank you. For those of you that are on the phone that I can't really see you waving at me because you're on the phone. Anyone there want to unmute yourself and ask a question? Please do so now, and my apologies for not calling you out sooner. Go ahead, and if you have a question, now is your time. Okay. Any other questions? And as we move into our case presentation, if questions come up, we can go back to that as well as we work through the process. Thank you folks so much for the presentation on the didactic this morning. What we're going to do is we're going to move into our case presentation, and Entira Family Clinics and Ellen Ratz is going to go ahead and speak. But before that, what I'd like to do is just give you a quick review of what to expect. So what we're going to do is we're going to hear a brief case presentation, and then we're going to have the opportunity for asking clarifying questions about the case so that we can understand the details a little bit better. The folks that we have on, we have what we call our learner or our spokes. We'll let those folks go first with clarifying questions, and then we'll go to our core hub or our subject matter experts, as we call them, to go ahead and ask clarifying questions. And then after that, we'll go into recommendations, and then we'll do a summary of the case. So just to kind of give you an overview. So Ellie, would you go ahead and just give us that really high-level overview of who Entira Family Clinics are, and then go ahead and go into your case presentation?
Good morning. So my name is Ellie Ratz. I'm a nurse practitioner with Entira, and I work at our East Side location. Entira has 10, and I'm sorry, can everyone hear me?
Yes, Ellie, we can hear you.
So we have 10 clinics throughout the St. Paul area, some in suburbs, some in St. Paul. And we're a mixture of NPs, PAs, and physicians. And so joining me today is also Lisa, who's our RN, Lisa, who is our case manager, and then Lynn, who's our clinic manager. And so my clinic is located on the east side of St. Paul, kind of more in a diverse neighborhood. So we see every kind of thing from new patients, new immigrants, to elderly patients, everything in between. And so we can go to the first slide. So we're looking at just the population-based and what are our resources really to target these patients with mental health, and specifically mental health and chemical dependency. And then we can go to the next slide. And so our clinic sees a large number of patients with both chemical dependency and mental health. We have patients with alcohol use disorder who are interested in IM naltrexone, but unfortunately we're not able to find those resources at this time. Our clinic does have 3 providers who provide Suboxone for opioid use disorder patients with mental health and just opioid use disorders in general. And so one of our biggest barriers is looking at patients with chemical dependency and mental health, and how do we find available resources for both. We often have patients who are motivated when they come to clinic, but then there's that time in between where we are trying to find resources and they lose their motivation. And so kind of in our broader context, we're looking at patients with, what's our immediate resources we can get patients when they come in, when they're motivated, and how do we help them the best. And then we can move to the next slide. So our clinic overall, we're interested in learning about evidence in primary care clinics for administering patients naltrexone or other medications for chemical dependency who also have mental health concerns. And then we can move to the next slide. So what we're hoping to gain today is just more information on community resources, what other clinics have used, and what we can do to help our patients. And then we can move to the next slide. So looking at this cross framework, our population based, one of the things we have is a patient who excuse me, just one second. Excuse me, sorry. So she's a 27-year-old woman. She's a Hmong woman with hepatitis B, alcohol use disorder, and has had a history of seizures. She also has alcoholic cirrhosis, depression, and anxiety. We've seen her multiple times. So she's had 3 hospitalizations in the last 6 months and 4 ER visits for alcohol use. She's completed multiple Rule 25s, but not moved forward. Excuse me. So with that, when she's been in the hospital, she's seen the social worker, she's worked with the Mobile SUDS program intermittently, and she's also been prescribed naltrexone and fluoxetine for her depression and anxiety. Her barriers include frequent no-shows of appointments, she has limited access to the phone, and she's been referred to counseling but hasn't attended. And then we can move to the next slide. I'm just going to mute myself for 1 second.
And Ellie is sharing this patient as kind of an example of the population of folks that they are seeing in the clinics that have this multiple of substance use disorder as well as mental health issues and other factors that are barriers. Ellie, go ahead.
Thank you. So yes, as you said, so she's a prime example of many patients that we have. Some of her background is she's a stay-at-home mom. She does live with her significant other who doesn't drink alcohol, and he has been engaged in trying to encourage her to seek treatment. She does endorse that she most days drinks 10 to 15 shots and then also several beers. Looking at her family history, she has very limited resources. Her mother's an alcoholic and lives out of state. Her father died when she was younger. She doesn't have family support in Minnesota. She does have a good friend group, but she identifies them actually as triggers because that's who she generally drinks with. Anytime she's in clinic, we often, or on the phone, we say, these are our different resources, and her answer generally is, I'll be okay. I just want to be home helping my child. She has been referred to GI multiple times for her alcoholic cirrhosis, but she hasn't followed through with them. She's declined counseling. We've talked to her about AA, specifically women's groups that have childcare. She's declined that. She oftentimes, when she comes to clinic, she does just endorse, I'm very interested in the IM naltrexone because she doesn't take the oral regularly, but we haven't been able to find resources for her. We've also encouraged inpatient CD treatment, but she's declined that just because she wants to be with her child, obviously. So looking at her background, she doesn't work, or she does talk with our case manager frequently, and she will send messages through our web-based portal. She recently did get a part-time job, and so she's hoping that will help her be more motivated and stay sober, just because she's obviously being more busy. She continues to verbalize motivation, but she doesn't follow through on the resources. And then because she is Hmong, we thought, are there cultural barriers? We looked at different groups in the area for counseling that do have Hmong patients, and we can't really identify any cultural barriers at this point. So the resources that we're using so far is she's working with our healthcare home RN, she's working with our case management, she's used the Mobile SUDS program intermittently, and then we've also referred for counseling. And so looking forward, we're just hoping, potentially maybe some inpatient CD treatment if she'll be agreeable, or if there's areas that maybe she could do the IM naltrexone if we could find resources. And so I think our biggest question and what we're requesting today is, other than motivational interviewing, what do people recommend to get her engaged in CD treatment? Are there resources that people know of for IM naltrexone or other options for patients like this? And then what other kind of things have other groups used? Are there resources that show that primary care clinics have improved their chemical dependency remission rates if they offer IM naltrexone?
Okay. So just a quick high-level summary of what I think I heard Ellie share with us. is the patient population is one that has both substance use, be it alcohol or other substance use disorders, potentially with mental health issues, and then other factors that are getting in the way, no showing for appointments, not able to follow through with perhaps like CV treatment, etc., and really looking for what are the community resources that others are utilizing, and then how are you getting like the IM drugs for the patient. So that's kind of that high level brief kind of snapshot. Ellie, does that kind of serve what you spoke to?
No, I think that's exactly what we're looking for, is kind of what are their other resources, what are other family practice or other clinics finding that are helpful.
Okay, thank you. So from there then, I'm going to ask you to stop showing so I can see everyone's face. We're going to stop showing the PowerPoint so that I can see all the faces of everybody on video. And then what I'd like to do is go into clarifying questions. And what I'd like to do first is ask those folks that are not on video, that are on phone, to go ahead and do you have some clarifying questions? If you do, please just go ahead and unmute yourself and share your question. Clarifying questions about what you heard from Ellie about their patient population, the clinics, the care that they're trying to provide for these patients. And I always encourage you guys, don't be shy. Anything can be launched out here.
Oh yeah, I have a question. This is Gretchen Buchanan. Can you talk a little bit about what avenues you've tried to take for the IM naltrexone?
So we've tried home care. We've also tried looking at, is there different psychiatry groups in the area that offer it? Because she's not homebound and because of the risk if she was using opioids, which she denies that she is, home care wouldn't administer it because of the precipitated withdrawal potential.
Thank you. Additional clarifying questions. Let's go ahead and go to our our learners organizations. Additional clarifying questions. You can wave at me or unmute yourself and go ahead. And Jenny, do I see you waving?
Yes,
Okay.
I'm just curious if the option of just doing the IM naltrexone in your own clinic has been explored.
So we are starting to explore that as an option. We do have protocols, obviously, with the Suboxone, and looking at kind of what the other protocols would be if potentially that's something that we could do in the future.
Let's go ahead and add the core hub organizations. Do you have clarifying questions as well? Anyone at this point can go ahead and ask clarifying questions.
Ellie, oh, go ahead.
This is Julie Erickson. I was just wanting to back up a little bit to the understanding the resources and where you're at in your integrated behavioral health journey. I guess I just was confused still a little bit about what is the makeup of your primary care team or the roles? What's the access right now to like to on-site behavioral health, like when, for example, when this patient comes in or similar patients, just to, I guess, kind of figure out where you're starting from and what we might be able to help suggest?
So on site, we have a nurse and we also have case management. So our case managers, what they do is they're more of our resource managers. We don't have resources within our clinic necessarily, but it's referring out for either psychiatry, counseling, Rule 25, things like that. And then on site, we obviously we have the providers and then the RN also.
Okay. Jeff?
Yeah. Well, first, I just want to say, Ellie, kudos to you and your team. This sounds like a really, really complicated, difficult case to try to manage. And I just have a question. I don't have any great advice, but and maybe you just didn't have a chance to present this, but is there anything in this woman's history that would shed some light on what it is that drives her psychologically to continue to use substances? You mentioned that she's Hmong. I didn't quite pick up whether she was born here or immigrated here, but I'm thinking of things like trauma or other kinds of psychosocial problems that may be contributing to the the maintenance of her abusing substances. Do you know much about that at all that you could share?
So I think, we do know that her mother's an alcoholic and that her father died when she was a very young age. I don't know about any specific trauma. She was born in the US. I think her parents likely had trauma and potentially PTSD. So obviously, depending on what she grew up with, that may have also shaped some of this. Unfortunately, because she comes to clinics so infrequently, we also don't have a lot of that good background yet. So it does make it a challenge.
Okay. Thank you. Other clarifying questions? We have time for another before we move on to further recommendations.
Laura from Fairview. I was curious, did you say our team members trained in motivational interviewing, using that to help engage the patient?
So all of our team members are trained in motivational interviewing, and we do kind of retraining regularly for that also.
That's great.
Okay, all right. Any last call for clarifying questions, or we'll move on? I'm gonna pause. Okay, Jenny, I see you.
I just want to go back to the IM naltrexone just to see, like, are there barriers to implementing, providing that in your clinic? Because it seems like that's something she might be motivated by. And so I'm just curious, like if you've tried and maybe people are just not open to it, or if there's some other barrier present.
So I don't think there's really any barriers. I think that unfortunately it's just the time of the process of developing our protocols and having staff trained and things in that way. And so that's one of our big goals moving forward, is to have that available.
Okay, thank you all very much for your clarifying questions. Let's go ahead and move into recommendations. And recommendations and impressions regarding the discussion that's been held about these care issues. And what I'd like to do is I'd like to go to those spokesfolk that are on the phone to give you the opportunity to go ahead and put a recommendation or impression out there. Those of you on the phone that I can't see your video. Recommendations. Okay, let's go ahead and add the rest of our spoke folks that are on video. And of course, you on the phone, if you think of a recommendation or impression, please go ahead and let us know. Recommendation impressions. Go ahead and unmute yourself and go ahead and offer. I don't see anybody waving at me either. Any ideas? Joellen, are you trying to speak? I can't. You might be muted. Okay. All right. Let's go ahead and we'll open it up to everybody on our session today. Recommendations or impressions for the Entira Family Clinics.
Well, this is Jeff, and by the silence of the group, I think everyone shares the sense of helplessness that maybe Ellie has and with her team. This isn't really a recommendation, more of an impression. I'm trying to think of, where is this woman in the stage of change model, and she seems to be kind of in the contemplation stage. In other words, that she seems ambivalent. Part of her wants to make some changes, part of her doesn't. Her friends seem to be triggers for her drinking, and yet she wants to be around her friends. And so, when you have a patient in a stage of contemplation, sometimes the best we can do is to try to move them to preparation in that stage of change. So what does that mean? It can mean promoting positive expectations. It can mean validating their lack of readiness, clarifying that the decision to get well is theirs, not ours as the practitioner, and then just to encourage frequent reevaluation. And lest you think I have those things memorized, I refer to the stages of change so much, I have it on my bulletin board right behind my computer screen. So I'm not really as smart as I sound, but it just reminds me frequently about staying in my lane and realizing that I can't make people get better, but I can try to create an environment in which I hope they'll take the next step. And Ellie, that's probably of little to no value, but sometimes acknowledging that we're powerless is what we have to do until the patient is ready to take the next step. So I really salute you and your team in hanging in there with this woman.
Thank you, Jeff.
Thank you.
And I think as I'm waiting for others to indicate that they might have a recommendation or impression, if we take this up that level to the population health level and think about all of the patients that are coming in that are experiencing a level of some type of substance use disorder and mental health. So what are the opportunities? I've heard about the exploration of administering the IM medication in the clinic. Are there also the opportunity for support groups within the organization for these patients to meet together as an impression? Is that a possibility as a recommendation? Any jumping off or thoughts of sharing of that piece? What are you all doing with community resources that could be helpful for the Entira clinics?
So this is Gretchen Buchanan. I just wanted to say that I really liked what you said, Jeff. That makes a lot of sense. I have a couple ideas. One is, and maybe I should have asked this in the clarifying questions, but Entira, if you have looked at residential options for her that include that she could bring her child with her, something like Wayside or River Ridge.
So we have talked to her about residential options where her daughter could be there. Unfortunately, because she has a significant other, she's not interested in living somewhere without him also.
Okay, thank you. And I think that just kind of emphasizes what Jeff said, that she's definitely not in an action stage of change and probably not in a preparation stage of change, really in that contemplation stage, and helping her move to preparation is probably the next step. And it can be hard when she doesn't show up to appointments to actually make that happen. In your presentation, you had asked if there was any evidence for integrating naltrexone into primary care settings, and Jeyn sent me the slides yesterday, so I just did a quick lit search, and I did find a few articles that I could send to you guys. One is on collaborative care and alcohol and opioid use disorders. It's in JAMA Internal Medicine. And then the other one is in the Journal of Hepatology, just kind of overview of treatment of alcohol use disorders in patients with alcoholic liver disease. And both of those do talk about the primary care setting being an appropriate place for implementing various medications.
Thank you, Gretchen. Other thoughts out there, impressions, recommendations?
So here at Open Door, and I know we're really lucky because we have a pharmacy on site here, so it's relatively easy for us to do the IM naltrexone. But I do wonder, you know, like, has there been maybe some discussion about partnering with maybe a nearby pharmacy on doing this? You know, like, I have no idea if it would even be possible, but, you know, it's worth a shot just to try and reach out and find out if someone would be open to partnering on it.
Thank you.
We have not, but that thought about that yet, but that's a great idea.
This is Mirza from Alina Health. Also, transfusion centers might have an option. If we need to get a patient an intramuscular injection, we go through actually the hospital infusion clinic at our primary care site where they don't do IM injections for antipsychotics and naltrexone and so forth.
Thank you. Other ideas, impressions?
This is Julie Erickson again, and I was thinking about the question of if you had some evidence, you know, if we were able to say, and maybe with Gretchen's resources, that yes, this being able to offer the injection on site really does reduce depression levels or has other demonstrated clinical benefits, at what that would, at a systems level for your clinics, be able to, what you would be able to do with that information. And I guess then again, just thinking at that population health level of, if you could take that information then, and it seems like being able to develop maybe more of a, like a clinical pathway, or, you know, sort of the level of beyond, like, this is a really great and very difficult case example, and I'm sure, again, she's representative of a number of other patients with similar challenges for your clinic, so her own, but then for your clinic and your staff, to be able to say, you know, what are the resources that we have? It seems like you have a solution that might help to solve the problem, but, you know, this particular patient seems like she might then have some other, you know, reason to decline that, but more of what are all the strengths and resources that your clinic has as a team, and what might, you know, what are the gaps or the opportunities, and maybe using some of this information to take it to a more a systems level, because it seems like it's a really hard, just as a patient or even a provider, or maybe even a one primary care team to solve.
Thank you. Yes, Joellen?
As I was hearing the case example, thinking about it sort of at maybe the next level up at a population level, perhaps we have an opiate oversight committee, which helps sort of a lot of our providers deal with patients who are addicted to opiates. Perhaps we could think about, or the organization in Entira could think about, maybe sort of the same kind of panel to deal with patients that have substance abuse issues, you know, in a more broad perspective, might help. I agree with the last speaker, Julie, that one provider or one small clinic dealing with these patients is difficult, but if we could bring a lot of folks together, perhaps we could do some panel management and help at that next level.
Thank you. Okay, we've got time for one more recommendation or impression. Anyone have one more thing to share? Okay. What I'd like to do is we're going to go ahead and ask for a summary of the recommendations. Gretchen, can you go ahead and share the summary of recommendations, please?
Yep. So I'm just pulling it up. All right. So The first kind of main recommendation was from Jeff, talking about really digging into the patient's stages of change and recognizing that if she's in contemplation, the job is to move her to preparation, and then really just kind of thinking that through and analyzing that. How do we do that? There was a question, potential recommendation about having support groups within the organization for this patient. And then clarifying question / recommendation about residential options with child also being able to go with. Then there was then I suggested that I'll send out a couple articles that I found about the appropriateness of naltrexone. And then we had a recommendation about partnering with a local pharmacy, and then piggybacking off of that, a transfusion center. Then we also had kind of two joint recommendations, thinking about creating more of a clinical workflow, panel management, creating some type of consultation panel or group within the organization, so that when individual providers and clinics come across patients like these, they have somebody to consult with on a regular basis, which would make it hopefully easier for those providers.
Thank you. From the group, is there anything else that you wanted to call out for the recommendations? And the second question is, was this helpful? Go ahead and unmute yourself and just go ahead and share if there's further recommendations to add to this list. And or the second question, was this helpful today?
So I think just looking at the different resources and recommendations was very helpful, and especially just what Jeff said about thinking about where her motivation is and where she is in the stages of change really makes a big difference too.
Thank you. Any other closing thoughts, any questions that have bubbled up from the didactic that we had earlier? Anything else that if you didn't say it now, you would feel remiss about that all day? I don't see anybody waving. I don't see anybody unmuting. Okay. The next slide, please. So in closing then, what I'm going to do is I'm going to wrap this up and say you're going to get a SurveyMonkey evaluation for this session. Please respond and get it back to us, please. And next time is going to be February 6th, and it's going to be mHealth Fairview is going to do our didactic, and the Lake Superior Community Health Clinic is going to go ahead and do our case presentation. And as you noticed, we are raising the level of the case presentations to a more system level or a population level, etc. So the individual case presentations are not really individual people. The highlighting of that is really helpful, but we really want to get to a higher population health level so that we can really dig in. Thank you all very, very much for your time and your participation today. We look forward to continuing this at our next session. If you have questions, please let me know. We will get out the summary and the recording and things to you within the next few days. Thank you all and have a great day. Bye-bye.
Bye, everybody. It was a great meeting.
Thank you. Thank you again.